Hi, welcome to the webinar on composite indicators. I am Pinar Kara. I am a HealthPros Fellow and PhD student at Danish Center for Clinical Health Services Research, Aalborg University, Denmark. And today I will make a little introduction to composite indicators for quality of healthcare. Let's start with some definitions. Quality of healthcare can be defined as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. In order to achieve good quality, healthcare should be efficient, safe, and people-centered. And to assess the quality of healthcare, indicators have been used. Indicators are quantitative measures that are used as guides to monitor, evaluate, and improve the quality of patient care. There are different options to classify types of quality indicators, and here is the Donabedian approach. In this framework, there are three dimensions of quality, which are structure, process, and outcome. Structure denotes the attributes of the settings in which care occurs, and some examples for structure indicators are hospital volume and access to specific units. Process denotes what is actually done in giving and receiving care, such as prescribing beta blocker at discharge for patients with acute myocardial infarction or counseling during hospital stay. And outcome indicators measure effects of care on health status, such as mortality, quality of life, and functional status. Because of the complexity of healthcare and wide range of relevant quality aspects, there are large number of quality indicators, and the availability of many different indicators may make it difficult for patients to select the best providers for their needs, and also for policymakers to decide if the overall quality of care is improving or not. And composite indicators can be very useful in such cases. A composite indicator is basically a combination of multiple individual indicators that results in a single score, and they have been widely used to assess quality of healthcare since they have some important advantages. Some advantages of composite indicators are listed here. Composite indicators can summarize complex and multidimensional aspects of quality of healthcare and report the quality with a single score, and by doing so, they can reduce the amount of data presented in quality reports and can be easier to interpret than trying to find a trend in multiple individual indicators. Composite indicators also can be easier to present and to get public attention. By using composite indicators, we can assess overall progress over time, and using composite indicators may result in increased reliability and precision. However, there are also some limitations regarding composite indicators. Composite indicators may be misused, may be misleading when construction process is not transparent or lacks statistical principles. Composite indicators may mask important differences and relationships between individual indicators. They may ignore dimensions of performance that are not easy to obtain but still important to measure. Different approaches of combining individual indicators may result in different scores, rank orders of healthcare providers, so the results obtained from composite indicators may be sensitive to the methodology that has been used. So composite indicators have some important advantages, but they also come with some limitations. And in order to maximize the advantages and prevent the potential problems regarding these indicators, it is important that composite indicators are subject to methodological testing and evaluation. A challenge with composite indicators is that there is not an agreed methodology to construct them, but there are recommended steps to consider to obtain a reliable, methodologically sound composite indicator, and I will explain them step by step in few sentences. First step is to define the theoretical framework, the purpose of the composite, and what exactly want to be measured should be clearly stated. The potential consequences of inclusion and exclusion of indicators in the composite should be considered. Second step is selection of indicators to be included in the composite. The indicators can be selected based on their types, analytical soundness, measurability, their reliability and relevance to what we want to measure. When choosing indicators, also there may be a trade-off between what is important for users about a provider and what can be in fact measured reliably, so this can be taken into account too. Next step is multivariate assessment to assess the overall structure of the data and interrelationships between indicators. Principal component analysis and factor analysis can be used to identify subgroups and group individual indicators according to their degree of correlation, and Cronbach alpha to assess internal consistency, so how well indicators describe the constructs. If individual indicators that will be included in the composite have different measurement units, also they should be normalized, and if there are missing values, imputation of missing data can be considered. Step 5 and 6 are the steps where methodologies differ from each other. Step 5 is assigning weights to individual indicators. Here are some approaches regarding weights, and I will explain some of them. In most of the studies, unweighted or equal weighted components are used, and this generally implies that all indicators work the same in the composite and they are equally important. This approach is preferred when there is no reason to believe some indicators are more important than others. However, there can be a limitation regarding this approach, which is called double counting. Double counting occurs when in the composite there are some indicators which are highly correlated with each other and measure same aspect of quality. So when we give equal weights to all indicators because we think all domains are equally important, we may be given more weight to a domain if there are multiple indicators measuring that aspect. This may also result in indicator rich but information poor composites. So it is important to assess overall structure of the data, including correlations, before just giving equal weights to all indicators. One other option is using weights obtained by an expert panel. For composite indicators, statistical weights can be also used. In regression weights approach, each component is weighted according to its association with an endpoint. If an indicator's association with the endpoint is stronger than others, this indicator receives a greater weight. Each component of the composite is multiplied by its odds ratio. And when calculating the weight of an indicator, other components' impacts should be adjusted. Regression weights are most preferred when there is a gold standard endpoint and there is no high correlation between individual indicators. The next approach is weights obtained by principal component analysis or factor analysis. This approach is preferred when there is high correlation between individual indicators. The use of principal component analysis or factor analysis is mainly motivated by the problem of double counting. So, as mentioned earlier, when there is high correlation between individual indicators, those indicators may be measuring same aspect of the quality and they may share some underlying characteristics. With this approach, we can group indicators which share similar characteristics together and weight components according to the amount proportional to their factor loadings. And of course, these weights can be adjusted before getting final weights. And of course, these methods can be sensitive to the factor extraction and to the rotation methods that's been used. After assigning weights to individual indicators, next step is aggregation of these indicators into a single score, and there are multiple ways to do it, such as opportunity scoring, indicator average, all or none scoring, and 70% standard approaches, and I will explain them. Opportunity scoring is the most used scoring method for composite indicators, and in this approach, partial performance is awarded. It basically counts the number of times that appropriate care is given divided by the number of times that it should be given. And it can be investigated under two subgroups, which are overall percentage and patient average. In overall percentage approach, the numerator is the total number of care indicators given to all patients in the hospital if we are calculating on hospital level, and the denominator is total number of care indicators that should be given to those patients. And here is an example on how Centers for Medicare and Medicaid Services calculated hospitals' heart failure composite quality score for their Hospital Quality Incentive Demonstration Project. Here, patient 1 is eligible for 4 indicators and received 2 of them. So this patient's contribution to numerator is 2 and to denominator is 4. This is done for every patient in the provider, and provider's quality score is calculated this way. Patient average is quite similar, but in this approach, we calculate the composite score for each patient by dividing the number of care indicators that has given to that patient to number of care indicators that should be given. These indicators are at patient level and they can be averaged to get hospital level composite scores. And here is a little example regarding patient average approach. In indicator average, composite scores are calculated on indicator level. For each indicator, the percentage of patients for whom the indicator was met is computed, and then the scores are averaged across all indicators. This approach is preferred when indicator level scores are the only available information. And the composite scores obtained by using these 3 approaches that I've just mentioned will be same if all patients are eligible for all indicators. The second most used approach to create composite indicators is all or none approach. In this approach, the care of a patient is counted as success if only all of the care for the patient is met. It doesn't award partial performance. It is either all or none, and it is the strictest measure among them. For example, if a patient is eligible for 6 indicators and received all 6 of them, this patient gets 1. And if this patient receives 0 indicators or 5 indicators, it doesn't matter, this patient will receive 0. So it is calculated on patient level. Each patient gets 0 or 1, and then these scores are averaged to get hospital level composite scores. It is preferred when providing anything less than complete care is not enough to achieve success. And the last approach I will mention is 70% standard and other thresholds. This is similar to all or none, but with a less strict threshold. In 70% standard, the care of the patient is counted as success if only at least 70% or more of the necessary care indicators are given. Like all or none, scores are calculated on patient level and then averaged to get hospital level composite score. As the last step, composite indicators should be validated. Even if the individual indicators that has been used in the composite are already validated indicators, After giving weights and aggregating them, the final indicator may not be the true reflection of quality, and validation is still an important step. For validation, content and face validity, concurrent validity, and predictive validity can be assessed, and internal reliability of the composite can be investigated. So let's summarize all of this. Quality of healthcare is important for all users and it can be measured by using quality indicators. However, healthcare is complex with many aspects and many indicators, which may make it difficult to interpret and to present. Instead of using multiple individual indicators, we can combine them and summarize quality with a single score. A composite indicator is basically a combination of multiple indicators, and there are different methodologies to create them. And these methods differ from each other in terms of weighting and aggregation. Each individual indicator's effects in the composite can be modified by assigning weights, and some approaches regarding weights are equal weights, expert weights, regression weights, and weights obtained by using principal component analysis or factor analysis. After assigning weights, these indicators are aggregated, and some approaches regarding aggregation are opportunity scoring, indicator average, all or none scoring, and 70% standard. So there are different methods and we can expect that these different methods will give different results. In other words, composite indicators can be sensitive to the methodology that has been used. Therefore, to get reliable composite quality scores, it's important to consider limitations and different approaches and being transparent regarding construction process of the composite. And validation of the composite indicator is an important step. This was a little introduction to composite indicators. Thank you for your attention and please feel free to email me when you have any questions.